about how to look for cyanosis in a person of color, right? In a person of color, it's very difficult to get a feeling for cyanosis. But if you look in those areas, if you look at the lip and look behind the lips, and you'll see that cyanotic color that the pink turns to blue. And Rohan just for the word ashen. That's where you have a problem. That somebody who's a person of color, if you try and get you consider ashen as an indicator, they're not, right? I mean, it's very difficult to see ashen when you're looking at somebody with dark skin. So that's the way to look for it, just behind the lip. It's a great indicator. There
Absolutely.
you go. Baby's all settled.
No, thank you, appreciate it. So where was I going here? So work of breathing. We're talking about breath sounds, positioning, looking for that nasal flaring, and then circulation, as Dave just said, pallor, modeling, and cyanosis. So making sure we're keeping of that, and we're looking for abnormalities of this. And we go into, and I know Charles knows because he sat through the EPC class with me. You know, you look at the kid. Do they look sick or do they look not sick? Sick or not sick? I think we got tired of looking at pictures and going sick or not sick. Because that's what you have to evaluate. We want to use that. Sorry, that was really bright lightning next to my window. Employ the ABPU method. So they're alert. Do they respond to verbal stimuli, respond to painful stimuli? Are they unresponsive? I shouldn't have to say this, but don't ever shake an infant or child. That causes a whole other mess of problems. And airway and respiratory problems are the most common cause of cardiac arrests in infants and young children, which is why we start CPR when on an infant? Anybody? Tori, you're muted.
Is it immediately no matter what?
Yes. Immediately.
Anytime their heart rate is actually below 60.
Less than 60.
Correct.
All right. So big things to focus on. Is the airway patent? Right? Is the airway maintainable with head positioning, suctioning, or any adjunct? All right. Is it not maintainable? Those should be big things. Respirations are insanely important in kids. So these are just some pictures, opening the airway in a child. You can see they're using their thumb to kind of pull the tongue and the jaw forward a little bit. Head tilt, chin lift, and note we're not going to overextend that head. Right, a jaw thrust remover, jaw thrust maneuver, not remover, maneuver. That. Okay. So any questions so far? Maybe.
I would add, and I know it's a specifically more related directly to CPR, but if you're trying to open a child's airway, as Jamie mentioned earlier, the whole issue of getting them into the sniffing position is important. And because the occipital area of a child's skull sticks out, kind of always pushing the head forward and closing off the airway. If you can get and I mean, there you go. If you can get some sort of support, and it's not in the neck, you're not trying to, it's not a car safety seat, you know, where you're trying to support their neck. It's actually supporting their shoulders so that it straightens out their airway and gives you that ideal sniffing position. That's the very easiest thing to do to get a child's airway in the right position.
Absolutely. All right. So just kind of continuing on here. So primary assessment, look at chest and abdomen for movement, listen for breath sounds, both normal and abnormal, feel for air movement at the mouth, and just always remember that pain or fear can increase that child's respiratory efforts. If you suspect trauma, check for life-threatening chest injuries, right? Look at their respiratory rate. When we talk about tachypnea, this is often the first manifestation of respiratory distress in infants. And a slow respiratory rate in an acutely ill infant or child is actually very ominous. So pay attention to that. Looking at respiratory effort, so the quality of the air Entry assessed by observing chest rise, breath sounds, maybe listening for stridor or wheezing. The color, that's a cyanosis, is a fairly late sign of respiratory failure in kids. We're going to assess circulation by their color, check capillary refill time. When we think of their heart rate during the primary assessment, infants develop sinus tachycardia in response to stress. Bradycardia may indicate that hypoxia, and again, that's an ominous sign of impending cardiac arrest. So does anybody know what the average heart rate for an infant is? It's a range. Oh, I got a chat. Chat. Who's chatting with me? You're about right, yeah. Somewhere in the 120 to 180 range, Rohan. That's correct.
130.
It's significantly higher. When we look at peripheral circulation, peripheral pulses are a good indicator of adequacy of end organ perfusion. When we lose those central pulses, that's a very ominous sign. I love the word ominous if you couldn't figure it out. When we think of end organ perfusion, this is evident in the skin, the kidneys, and the brain. So having decreased perfusion of the skin is an early sign of shock. When we think about the brain, you're going to have a change in mental status. They may become confused, lethargic. They may have seizures. Failure for a child to recognize their parents' faces, bad sign. Urine output directly relates to kidney perfusion. And one of the things that we learn in PALS is early recognition of those physiologically unstable children. So risks that increase cardiopulmonary arrest: respiratory rate greater than 60, a heart rate greater than 180 or less than 80 under 5 years of age, or a heart rate greater than 180 or less than 60 of over 5 age. Respiratory distress, trauma, burns, cyanosis, altered level of consciousness, seizures, fever with petechiae, progressive deterioration in respiratory and cardiac function. These are all indicators for cardiac arrest.
Petechiae.
So petechiae happen, what's the best way? It's like little red spots. Let's see if I can find you a picture of petechiae, because it's usually better with pictures. I like pictures, at least.
Just, a lot of new folks on here. You're throwing $5 words at them.
Yeah. So you think of a petechiae rash. Most time people will see it when somebody's been strangled. You'll see petechial hemorrhaging around the airways and things like that. But it looks like this, just little red splotchy rashes. At least that's where I first was introduced to the word, was CSI.
For kids, though, you should mention that the petechia dots aren't always that big. Like my son, CJ, gets it when we do jits, and as he gets out of breath, he actually starts getting petechia around his mouth and his nose. If he's being choked or anything, or if there's an arm bar and they're getting a real strong grab, wherever the grab was, he gets little red dots all around. Not a bruise itself, but it almost looks like little bursted blood vessels right at the top, but doesn't rip the skin. So there's no bleeding, but it just looks, but they're pinpoints. So they're very tiny little red dots all the way around, on children at least.
Yes, they're not nearly that big. Those pictures are adult petechiae, because little people, little spots, right? You have, this transitional phase. You can have a conscious, non-acutely ill child, and then all of a sudden they can go, I'm okay, and then they go, boom. So we want to try to figure out what's going on as early as possible so that we don't have the cliff, all right? We want to try to allow for the infant or child to become familiar with you, the equipment you're going to be using, again, going back to letting them play with your stethoscope or whatever it may be. When we think about their secondary assessments, looking at the history, involve that family member, caregiver. Older adolescents, we want to question in private. They may have some things they don't want to talk about in front of mom or dad. These are all standard things, chief complaint, nature of illness, length of time, presence of fever, especially in little kids, their bowel and urine habits, vomiting, diarrhea, frequency of urination, all very, very important. Because especially in infants, their urine output is an indicator of how well they're eating and if they're dehydrated or not.
Hey, Chief, I got a question on this, and I didn't get it answered at that class we went to. So urine outputs, if they actually specifically said, ask parents how many diaper changes they had, how many wet diapers, how many.
Yep.
So if a parent tells me that they've had 4 wet diapers, what the hell does that translate to hydration wise? Does it mean a quarter of water, a pint of water, a drip? I don't know how to do that when it's.
We don't really look about that. When you think about a baby, if you remember back to when your kids were infants, what did they do? They ate, they went to the bathroom, and then they slept, right? So every time they were eating, they would go to the bathroom, whether it be urine or bowel movement or whatever. So you want to see anywhere between 6 and 10 wet diapers in a 24-hour period. My daughter actually had a cold last year, and I was suspecting she was dehydrated, and she had a wet diaper at 6 o'clock in the morning, and we went to the pediatrician that afternoon because she hadn't been eating or drinking. And I was told that if she didn't have a wet diaper again by 6 o'clock p.m., that we needed to go to the hospital because that was an indication of 12 hours with no urine output, especially in someone her size, is dehydration.
Don't know, Jamie. If I never see another wet diaper again in my life, it'll be too soon.
Oh, well, you're about to have a grandkid. Have fun. I don't know. My daughter recently, in the past couple of days, has figured out how to take off her diaper. That's fun. When we're looking at physical exam, we want to carry that out only after any life-threatening conditions are identified, addressed, obviously. If there's a significant mechanism of injury or the patient's unresponsive, we want to do a complete rapid trauma assessment or a rapid medication assessment, obviously. Again, like I said earlier, we're going to do a toe-to-head approach for your younger children, a head-to-toe approach for your older child. Looking at pupils, capillary refill, hydration, pulse oximetry. In your secondary assessment, we can do the Glasgow Coma Scale. You should all know that. Obviously, you're going to have to make some modifications for pediatric patients. If you have a 1-year-old, you're not going to, they're always going to feel that how they talk to you level, right? We want to take vital signs with a patient in as close to a resting state as possible. We're looking at pulse, respiration, blood pressure is more important with age, infants not so much, temperature. Make sure you're using an appropriate sized cuff. Can't stress that enough. And remember that in babies especially, hypotension is late and often sudden sign of a cardiovascular decompensation. So. We can look for peripheral, brachial, femoral pulses, get a good estimate of their weight, look at their respiratory rate for beginning examination, measure temperature early in the patient encounter. The best place to take a temperature on an infant is rectally. So what they're looking for.
All right, I gotta chime in then again because I was told explicitly when I got to the station, nothing goes in any area of that for a child, period.
In our jobs, you are correct. Because nobody wants to stick anything into the rectum of an infant in a bumping, moving ambulance. It's probably not the best thing in the world, but that is what they're going to be looking for at the hospital. It's probably the first thing they're going to do is going to flip the baby over and stick the thermometer up their butt. You can ask if it's not a severely acute child, if the parents have done a rectal temperature or if they have a rectal thermometer that the parents can use. But in MIMS EMT world, they don't like us to do that.
Yeah, I'm tracking how to do it and why to do it, and you get a better core temperature and all that. We actually, that is our procedure for soldiers on heat injuries when you pass out when we're out doing it. Oh yeah, well we'll find out if you're faking it real quick. You're gonna have yeah. So anyways, I just wanted to bring it up because when you mentioned it, it was something that they told us in school that under no circumstances do you get to do that. Yeah,
it's a faux pas, but it's the best way to do it. That's why I said get the parents involved. Right. Observe their level of consciousness. Lots of non-invasive monitoring we can do. Pulse oximetry, capnography, using your automated blood pressure devices, a self-registering thermometer. We have them on our life packs, a little sticker we can put on the kid, and the life pack will actually watch the temperature for us. EKGs, ECGs. With any seriously ill or injured child, we want to make sure that they have continuous pulse oximetry. All right, and we're looking for 95% or greater. Capnography is great if we suspect sepsis. And before we apply anything to the kid, especially if they can understand what you're doing, make sure that we explain it so that they're not scared. We're going to continuously monitor their respiratory effort, their skin color, their mental status, their temperature, their pulse oximetry. We're going to retake their vitals, the standard stable every 15, critical every 5, because, like I said before, kids compensate, and then they fall off a cliff. So can't take too many vitals on a kid. So when we're talking about respiratory management, basic airway management, top priorities, airway, breathing, circulation. All right, so for our BLS providers, maintaining that airway, artificial ventilations, chest compressions, make sure they're in a supine position, avoid that hyperextension of the neck. Think about foreign body airway obstructions. All right, we give those 5 back blows, 5 chest thrusts. We never, ever, ever do a blind finger sweep. We can lodge things further down in there. Suctioning, all right? We want to apply suctioning whenever you detect heavy secretions in the nose or mouth. You can use a bulb syringe, a flexible suction catheter, or rigid suction tip catheter, depending on the age and size. We want to decrease the suction pressure to less than 100 milligrams of mercury in infants because you can actually suck their breath away. That's kind of what it is. We avoid excessive suctioning time, avoid stimulation of that vagus nerve because it runs down the carotids here. All right, frequently check their pulse when you're suctioning because you can cause them to vagal down. So oxygenation, huge, okay? This is the hallmark of pediatric patient management. Excessive oxygen can also be harmful, so we got to do this the right way. Use our pulse oximetry to guide supplemental oxygen administration. We can do blow-by techniques for our neonates, our pediatric size non-rebreathers, lots of different things we can do there. You know, try to overcome the fear these kids might have by demonstrating the face mask yourself. Right? Show them it's not that bad. Here, look, I'll do it. Or here, mommy will do it. All right? If they refuse that non-rebreather, high concentration blow-by oxygen. We only want to introduce adjuncts if you have prolonged artificial ventilations. Dave is saying we carry pediatric pulse ox clips. There's a penguin and other animals and something about a salmon, like the fish. I have no idea what it means. So we have oropharyngeal airways. Just like an adult, we only use these in patients who lack a gag reflex. Use a tongue blade to depress the jaw and the tongue, especially in an infant because they have that big tongue. Tip pointing toward the tongue and pharynx so it goes straight in. We don't do any rotations. Children who possess gag reflexes require prolonged artificial ventilations. We use our nasopharyngeals. Again, we don't use those if you have any trauma there. Appropriately sized, soft, flexible tubing, water-based lubricant. Avoid excessive bag pressure and volume, okay? So we're going to ventilate at that age-appropriate rate. This is a good time to use that capnography to monitor and guide it. Make sure you have a good fit. Make sure we are only pressing down. We are only squeezing that BVM until you see chest rise. Once you see chest rise, air is where it's supposed to be. You don't have to squeeze it to death every single time. That's how we get that gastric distension and overinflated lungs and things of that nature. Chest rise, allow adequate time for full chest recoil and exhalation, right? And that helps us assess that BVM ventilation. When we're talking about our ALS providers, we're expected to master these procedures, okay? If a child's airway cannot be cleared of a foreign body by basic airway procedures, we can use a laryngoscope blade and McGill forceps to remove it. Right? This is what a pair of McGill forceps looks like. They have them in lots of different sizes for big people and for little people. They're little, like tweezer looking things that are bent at an angle, and we will actually go down in and pinch and remove the obstruction. If you can't remove it, they recommend that we try to intubate around it using a smaller endotracheal tube. If the foreign body cannot be removed, and there is no way to intubate around it, we can consider cricothyrotomies by needle only as a last resort. And our local protocols are right here. Put them up here for everybody. If they're over 8 years, you can do surgical. If they are under 8 years, you have to do a needle cric. You're not allowed to do a surgical crike. This is like, they're going to die. You cannot obtain an airway by any other method, is when you move on to this. For those people who do not know what we're talking about, a cricothyrotomy is surgically or using a needle to access the airway. So the needle will go into the throat down here, so that we can get past whatever's obstructing it, or we will use a scalpel and create a hole, almost like a tracheotomy, and put a breathing tube down there so that we can breathe for these children that are having breathing problems. With endotracheal intubation, we're going to use direct visualization of that lower airway through the trachea, bypassing the entire upper airway. The most effective way of controlling it. It's invasive, very little room for error. It's a very hard thing to do, especially in babies. It's very difficult to create a single clear visual plane from the mouth into the glottis. So we prefer a straight blade laryngoscope, a Miller. For larger children, you may be able to go to a Mac. When we place when we intubate a child, we also want to place a nasogastric tube, because you have gastric distension. So it's a little tube that goes through the nose down into the stomach to relieve any air that may be in there. Pediatric patients who have any head or facial trauma, we're always going to do this for, we're not going to do this for anything that has soft tissue damage in the nose or inducement of vomiting. We're going to avoid this. With that, age-appropriate NG tubes, a 20 ml syringe, water-soluble lubricants, emesis basin, tape, suction equipment, stethoscope, all things you want to have. I haven't seen a NG tube placed at the MICU in just about the entire time I was there until like 2 weeks ago by Andrew. He was like, I need a new NG tube syringe because I used it. The one that we had for the past 5 years, it's now been used and we have to replace it. He did a really good intubation where they noticed some gastric distension and right on down, did what it was supposed to do. Looking at circulation, looking at the respiratory and cardiovascular systems are independent. So we're going to assess their body systems. There are two problems that lead to cardiopulmonary arrest in children: shock and respiratory failure. Right, those are the two big ones. Intravenous techniques are for children the same as for adults. We only use the external jugular vein for life-threatening situations. Actually, the use of an IO infusion is more popular in treating pediatric patients if we can't get along. Indications, same as anything else. Shock, cardiac arrest, unresponsive, sepsis, unsuccessful attempts at a peripheral IV insertion. Contraindications, obviously, we're not going to drill into a bone or any fracture of the pelvis or extremity fracture in the bone proximal to the chosen site. Looking at circulation, it's a standard 16 or 18 gauge needle. We have a drill that we can use or a Jamshidi. We prefer the Jamshidi in babies. It's a lot less traumatic on them. It's just pop it on in. Twisting fashion, 1 to 3 centimeters below that tuberosity on the tib fib.
Can I mention a point there?
Yep.
So, medics should know this, but just remind you, particularly if you're in a stressful situation when you're putting an intraosseous needle in, you can change the outcome of the life of that patient if you put it in the wrong place. And the reason is that the epithelial plates at the end of the bones are where the growth plates are. And if you don't go far enough away from those plates and you put it into the plate, then effectively what you're going to do is you're going to alter the future growth of that bone. So really important to know where your positions are when you're putting in any sort of intraosseous device into a child.
Absolutely. That is so very important to know your landmarks. And for Tori and Charles, who are going into the paramedic program this year and next year, respectively, it will be drilled in your head. Dun-dun-dun. There's my pun. Okay. When we're doing IOs, we want to aspirate that bone marrow into the syringe to make sure we're in the right spot, and then we can apply our fluids. Accurate dosing of fluids in children is crucial, okay? Lots of math. Too much will kill them. Too less won't work, all right? So you're at both ends of the spectrum. So hypovolemic shock in kids is 20 milliliters per kilogram of an isotonic solution. In the state of Maryland, we use lactated burners. Fluid therapy is guided by the child's clinical response. We use mini drip administration sets. Infusion pumps are used in pediatric cases in hospitals and things of that nature. Electrical therapy, yay. All right, so when you shock an adult, all right, what is the lowest shock setting we can do on our life packs?
Are you talking about cardiac arrest?
Yes.
As opposed to pacing?
As opposed to like pacing somebody. If you're just, they're in cardiac arrest, initial shock. What's our average initial shock? I'll put it that way.
I just hook up the AED and it does it by itself. Nobody tells me what the jewel is.
On life pack, we use that. Around average, we're going to start off somewhere between 200 and 300, depending on the situation, depending on the different things. If we're trying to cardiovert, if we're trying to defibrillate, above 200. In a child, it's 2 to 4 joules per kilogram of body weight, so a lot less energy. All right. If unsuccessful, we're going to focus on correcting that hypoxia and acidosis, obviously rapid transport. C-spine stabilization in kids, when they sustain a significant head injury, assume neck injury is present. That x-ray doesn't ensure spinal cord injury does not exist, so keep that in mind. Use appropriate size pediatric stabilization equipment. One of my favorite things to stabilize a baby on is a kid. They're great for kids. You can use cervical collars, towel or blanket rolls, foam head blocks. We have commercial pediatric stabilization devices, short wooden backboards, long boards with appropriate padding. If the baby's in a car accident and you don't have to take him out of the car seat, leave him in the car seat. Best stabilization ever. Your kid. Make sure that we're using appropriate amounts of padding to secure infants, toddlers, and preschoolers in that neutral position. And if they are conscious, especially kids under the age of 5, are going to protest or fight this. They do not like to be restrained. All right, any questions? That's my kid. Hey, I put a Daphne picture in there. Had to. That was her last year. She was a year-old then, so. Isn't she just the cutest thing ever?
She's always beautiful.
Any questions? I know it was a lot of information, but.
I got one for the AED then. So the AED, since I've been teaching it and learned it from CPR as well as, or from Red Cross as well as from EMT school. In our AED is the same AED I would use on a parent, on an adult versus a child. I would just supposedly swap out pads if possible. And if not, they say it's okay to hit the child with the full size pads, which in my mind is telling me it's getting the full size current that the AED gives. But contrary to what you just.
No, I froze. No. You still here? Anybody? Hello? I'm back.
Did you hear the question?
I heard contrary to frozen.
Okay.
Okay, so the question is AED.